With that, let me introduce, actually, Kabir almost did the introduction for me. One of my questions for Stephen is how does he even work since his office overlooks Torrey Pines Golf Course? So they must have a requirement, interview only non-golfers or something like that. But more seriously, he's the director of digital medicine at the Scripps Translational Science Institute. He's a clinical cardiologist as well, and has, prior to joining Scripps, he was director of cardiovascular wellness and medical director for employee wellness at Geisinger HealthCare, and has a lot of experience in this industry, and of course is one of the innovators in digital healthcare. With that, take it away, Steve.
Great, thank you, and good morning, everybody, and thank you for inviting me. This is a great conference and very exciting. I want to start. Kabir did a great job explaining Scripps Translational Science Institute. It was started by Eric Topol 7 years ago. It sits both philosophically and physically in between the Scripps Research Institute and Scripps Health. So one of the largest healthcare systems in San Diego and one of the world's most successful basic science research centers. And there we focus on two main areas of translational medicine, genomics and mobile health technologies. And what we look at is as the fully digitized individual, and as the previous speakers have said, it's an extraordinarily exciting area. So I'm going to focus on the four aspects of my title: the trends, the issues, the realities, and then finally on the impacts of the providers. Let me start with a positive trend. And that's looking at this improvement in healthcare over time. So I'm a cardiologist by training, and this is a sign of the decline in cardiovascular mortality rate, starting in about the late 1960s and decreasing over time. So about an 80% decline in age-adjusted risk of cardiovascular deaths. It's pretty remarkable, actually, in how we're doing that. And how we actually achieve that is still actually being debated. But we've done great things in the healthcare system. But as everybody here knows, there's a lot of room for improvement. So this is a less positive trend, is the cost, and especially the cost in the U.S. and what an outlier it is relative to every other country. And you could say, well, if we're paying more because we're getting more, we're better off because of that. And so you look at this next trend, and that's life expectancy to healthcare expenditure per capita. And it's a pretty nice curve that fits well here in Western Europe, Japan, Korea, all kind of fit on this curve. The U.S. is an outlier, so its cost per life, the case care expenditure per capita and compared to life expectancy is right about with the Czech Republic. And so we really are not in virtually every measure of cost efficacy in healthcare, we're not measuring up. So there's a lot of room for improvement. So one of the big trends, and why everybody's here, and the previous speakers have said, is the enthusiasm for mobile health technologies to improve on this. And Secretary Sebelius, this quote from several years ago now, when we talk about mobile health, we are talking about taking the biggest technological breakthrough of our time and using it to take on one of the greatest national challenges of our time. That's extraordinarily optimistic, and it's great, and I believe that. And so there's a lot of enthusiasm around that, and that's been shown too in the investment world. And the predictions for that, this mHealth market of $26 billion by 2017, 64 million wearables by 2017. By 2020, 25 billion wireless devices transmitting data and disposable medical device sensors, over $6 billion by 2018. So a lot of enthusiasm, a lot of projections. This is different funding. These are data that was generously supplied to us by the Moby Health News folks, showing annual funding of patient-facing mHealth companies from 2002 to 2012. And you can see it's really taking off exponentially, reflecting the enthusiasm that we've talked about since the beginning of this session. So those are some very good trends and then some concerning trends, and these are coming together to kind of the two trends to address each other. But here is, I think, let me just highlight a couple of the issues behind these trends before I get into the realities. So this is that same curve of funding, and then in the bars on the bottom in the histogram is the amount of data being generated around mobile health technology. It's stayed flat essentially since 2002 to 2012, a very small uptick, but you see all this enthusiasm for the technology being developed. But from a standpoint of a healthcare system trying to implement evidence-based therapy, there's just a incredible lack of the evidence, and not only just your typical clinical trials, in fact, I'd argue not your typical clinical trials, but rather really pragmatic studies that act as roadmaps to providers, to healthcare payers, and even to patients, saying, how does this really fit in to what I do? And if we give a couple examples of where we're lacking in really the evidence of how well these devices and apps work. So you look at the what the FDA has looked at in terms of the efficacy of different apps. So of the over 43,000 healthcare-related apps that are available for download, the FDA's reviewed about 100 of those. Not that the FDA has to review all of those, but the ones that are really going to make a difference, the ones that impact your health and care, they should regulate and they should look at, and that's a whole different discussion of how they should do that. But reviewing only 100 out of 43,000 that are available suggests that there's a potential that there's a lot of snake oil out there, developers, and there have been, as a great example, there were two companies that actually the FCC had to shut down who were making millions of dollars by convincing people that an app where the light on your smartphone would cure kids' acne. And people were downloading that, and they were fined for how much money they downloaded, and both were fined as slightly over $1 million. So when people have looked at the evidence, this is Carolyn Free from the UK, a great investigator, looking at the evidence in mobile health. This is a recent review. So high quality, adequately powered trials of optimized interventions are required to evaluate the effects of objective outcomes. So a lot of languages say basically that there's no good evidence yet that any of this works. When you've looked at some of the really nice apps that are really designed for a specific purpose, so here, this is a study that looked at applications to to diagnose melanoma. So take a picture of a skin lesion and say, to bypass going to a dermatologist, making life real easy for you, and taking a picture and see. Well, in this study, they found the results to be highly variable, and that 3 out of the 4 smartphones missed about 1/3 of the melanomas. So told the individuals, if it wasn't part of a study, and you had this app and you wanted to diagnose your skin cancer, you take a picture, it says, nope, it's a benign lesion, and it turns out you actually had cancer. So there's a lot of work we have to do to make sure that if mobile health is going to achieve the potential it really should and needs to, but we have to do it in an evidence-based way, and the technology is outpacing that evidence. So let's look at some of the realities of why we so desperately need mobile health technologies and where they can fit in. And because of time, I could probably talk several hours on the technologies in different areas. I'm just going to focus on 3 primary areas of need in the realities of mobile health and in healthcare today. So wellness is something that we do horribly in healthcare, in the general healthcare system, and it's usually done outside of healthcare. And maybe a reflection of that is how poor we do as a nation in healthcare when you think back to the cost and how bad we do in life expectancy. So in the spirit of the Olympics, we're winning in obesity overall. And you can see it's not only mildly winning. You compare us to, Switzerland on the far end of the graph here. I mean, we're twice the percentage of individuals, well over twice the percentage of individuals with who are either obese or overweight. And then possibly related and is our activity. Again, we're kind of winning on that side. It's just like golf. So we had the lowest, so we're the least active of all the countries too in terms of walking and cycling and things that we do. And really when it comes to wellness, we think of obesity and activity as being related. Activity is really something that we don't completely understand, but if you think about it, 3 generations ago in your family, pretty much you had to be active to survive. And if you go back 30 generations in the hunter-gatherers and stuff, you really had to be active to survive. So evolutionarily, we're built to be active. And in fact, people who study this, and I never understand how they can figure it out, would say that our ancestors used to walk about 25 kilometers a day. That was their normal. Today, if you meet your standards that the U.S. recommends, prevention guidelines recommend, you're going to walk 2.5 kilometers a day. And only half of the U.S. Citizens achieve that. So if you think about it, if genetically we're wired to be active, that when we're inactive, our body's going to assume we're sick or we're injured, because for our distant relatives, those are the only times they're inactive. And so we do go into this this mode of healing and sickness, where we metabolize our food differently, we become pro-inflammatory. So activity is related to a whole lot more than just calories in, calories out, not being obese, but it actually, the more active you are, not only you're lower risk for cardiovascular disease, but you're lower risk for depression, for diabetes, for cancers, for pretty much every aspect of health that you can imagine. So activity is not a minor thing. All right, so as an example of how important wellness is to the U.S. community, let's look at out-of-pocket costs at just some 3 broad categories of wellness. This is out-of-pocket. This is money that we're willing to spend for ourselves to be well. So one example, so 83 million adults will spend about $34 billion annually on complementary alternative medicines, that be massage therapy, acupuncture, and the like. Another $11 billion spent on vitamins and supplements, would be first to say no evidence that any of them are actually beneficial. And then about 108 million American dieters spent about $66 billion in 2013, almost all out of pocket, for weight loss programs. So that doesn't include our food choices and stuff, but that's joining Weight Watchers, joining Jenny Craig, and the like. So that adds up to be about $110 billion annually Americans will spend out of pocket for their own wellness, something that the healthcare system doesn't address. Probably not coincidentally, that's pretty close to the same amount of money spent every year on fast food sales. All right. So this is a really exciting area of mobile health, that mobile health technologies for the first time is going to allow us to address wellness needs. And the healthcare system, or some disruptive system, is going to have to take advantage of this information. So we've talked about the Fitbit already, and those are great, but we have monitors to tell how well we sleep. Sleep's a huge problem in the U.S. And if you can monitor yourself and get really useful information on the sleep quality, there's going to be a tremendous advance. And then on the bottom, many of these also measure stress. We have no objective evidence for stress in any of us, and all of us feel some stress. We don't know how to measure it. We've never have measured it before, but a lot of people will feel it differently. And if you can measure it, then you can do something about it. And all of us do something different when we're stressed right now. Some may take a walk, some people may meditate, some people may get a drink. There's a lot of options to do that, but you can find out if you can measure it, you can find out for yourself. So we're going to have an incredible amount of information. Probably all of this could be on one watch, or one wearable device can tell you your stress, your sleep, your activity levels, your pulse, your glucose, your blood pressure. All of that's going to be capable in the near future, and that's going to be an incredible technology that somebody is going to have to take advantage of to really help individuals and improve their wellness. Let me turn to a little bit of the current healthcare system, and that is generally, we all know, is generally centered around sickness care. And so the typical paradigm now is you have a patient, and she has a symptom, she drives herself, or it doesn't even have a symptom, a regular follow-up, and they go to wherever their source of that solution is. They'll go to the hospital, the emergency room, or to a doctor's office where they have all that technology there. Well, there's a lot of mobile devices now, and again, I'm just going to highlight 2 broad categories of those that can change that paradigm. And this is an overview from a review article that's in submission right now that just breaks down very broad categories of all the solutions that are available in this sickness care, and this is just kind of scratching the surface of it. But let me highlight then 2 areas. I'm going to do hypertension and then cancer, because cardiovascular disease and cancer are 2 biggest killers in the United States. Hypertension is the most common chronic condition in the United States. 1 in every 3 adults in America have hypertension. There's nearly $100 billion in total costs attributed to hypertension annually in the U.S. There are nearly 40 million office visits every year in the U.S. that have a primary diagnosis of hypertension. So that's the single most common diagnosis for an office visit in the United States today is hypertension. And I'll say this when I talk about the providers, but I don't think there's any physician who would tell you they needed to go to medical school to figure out how to manage hypertension. It's very precise. It's very algorithmic. There are several societies that have multiple guidelines on how to do that. I'd argue a good high school education and maybe a half day of training on a weekend can make you an expert on hypertension. Yet it is the most common diagnosis for an office visit today. And despite all that money, and how important it is, less than half of U.S. Individuals with hypertension have their blood pressure under control. Blood pressure explains about 80% of the risk for stroke and about 50% of your risk for a heart attack. In the United States, where it's the most common reason to go to your doctor's office, and we have the most expensive care in the world, that only half of the individuals who have this very treatable diagnosis are adequately treated. So there are a couple of solutions. We've had home blood pressure monitoring for ages, and this highlights, I think, what the true benefit of mobile health, and the other speakers have addressed, is the connectivity that allowed. So we know that home monitoring has a statistically significant but very small positive impact on improving blood pressure. So on average, if you have a home monitor, your blood pressure is 1 millimeter or 2 millimeters lower than those who don't have a home monitor. What really can make a huge difference is when that home monitor is connected to a provider, and we haven't had a really good study with a mobile device. We have one study ongoing now in collaboration with Qualcomm Life looking at that, but when Kaiser has done a study where they had pharmacists call patients, and so the closest is connectivity, led to a 20% absolute improvement in patients who had blood pressure under control by having that communication. And that's just this kind of asynchronous phone calls. Imagine if your blood pressures are automatically sent to your doctor's office or your provider's office, doesn't have to be a physician, shouldn't be a physician, and then they get feedback right away. You get a text message back, this is great, keep it up, or why don't we change your dose? And this is just kind of scratching the surface. So just yesterday, as a great example, Qantas made a public announcement that they exist. It's continuous monitoring of a watch that monitors your blood pressure. So every single beat of your heart, your blood pressure is tracked day to day, and or minute to minute, second to second. And that's incredible because I mentioned how frequent hypertension is, how important it is. I'll let you know the secret. We have no idea really what the best part of what hypertension we should be treating. Some people would argue your nighttime blood pressure is the only important thing. Other people have argued it's the variability in your blood pressure, not really what your label blood pressure is. So now we're going to have the capability to measure blood pressure continuously with different devices and much more easily, and we can, it's going to not only improve our treatment, or has the potential to improve our treatment, but it also is going to totally change our treatment of hypertension and how we define hypertension. This is another device that's going to change many aspects of care, the Scanadu Scout. Kabir mentioned the Tricorder X Prize in one of his slides. This is one of the more publicly more publicized entries into that, where you can hold this Oreo cookie-sized device against your forehead, and it can tell you your pulse, your blood pressure, your temperature, your respiratory rate. It can also, if you hold it there for 2 minutes, tell you if you're stressed or not. So this is the founder who's showing how that works, and it's going to go into studies in the next month, and it's going to be really incredible change. Okay, let me, on the last, the medical things, let me just talk about cancer. So yearly mammograms recommended for starting at age 40. That's always debatable, but in general, if you look at the guidelines, only about half of women actually follow the guidelines in terms of cancer screening. For men for colon cancer, or men and women for colon cancer, again, only about 50% of individuals receive recommended colon cancer screening. And then for lung cancer, for high-risk individuals, a yearly CT scan is recommended. That just started, and we don't know. So imagine if you could just, every time you talk on your cell phone, be screened for cancer as a real game-changing disruptive technology in healthcare, and we're heading down that in breath analytics. So about 1% of every exhaled breath is volatile organic chemicals. All of us have a very unique signature, it appears, in these volatile organic chemicals, and they correlate, they can be diagnostic for multiple cancers, infections, and other aspects. You can use it to see if you're burning fat for people who are dieting. You can diagnose tuberculosis with breath analytics. You can diagnose breast cancer, colon cancer, lung cancer, and I say diagnose a little bit optimistically, but in studies, you can do all of that. There's a specific signature for the diseases, so more we have to learn. And this is a Time article from about 6 months ago that looked at the promise of this. And this is one of the early technologies, this nanobeak technology, where you can see it's a clip-on to your smartphone. And the design is that while you're talking on your phone, it has a little motor that's going to suck in air, your exhaled breath, and it has the potential to screen you continuously for a multitude of very serious medical conditions. So let me conclude in a couple slides on this impact on providers, because if this was a provider audience, most of you would be like, well, I don't get paid. I already have bad enough patient-doctor relationship with my patients. This is going to really mess up my career that I'm already not very happy with. So I'm going to, and I'll show data, it's very sad. But so there's a lot of great technology for inside the hospital. Kabir again showed the Glassomics at Palomar. There's other technology, so I'm going to kind of skip that, and I'm going to focus on primary care providers. So in general, I mentioned that we're not a very happy group. So physicians rate the morale of 80% of their colleagues as poor to very poor, 80%. 2/3 of physicians would not recommend that their children or a young adult go into the field of healthcare. I think it is the world's greatest job. Can you imagine getting paid to make people feel better, to really to occasionally save a life, and to feel that 80% of people who have the opportunity to do that feel that they have poor morale or wouldn't recommend somebody go into that? That is a huge red flag that something is wrong in the way we provide care. 80% of physicians rate the doctor-patient relationship to be the most satisfying aspect of their work. But because the doctor-patient relationship is so challenged right now, and because of the very perverse financial incentivization in healthcare that exists in most fee-for-service environments, doctors don't feel like they have that doctor-patient relationship. So the average face time, 10 minutes, 40 seconds of that is talking about medications. And then we've set up healthcare providers to fail in the current system. So I think Michelle had mentioned the idea of having technologies have to fit into their care. I argue they have to do more than fit in. They have to make their care easier and better. Because already that if a primary care doctor was going to do everything that they were supposed to do to take care of a typical panel of patients, would take about 18 hours a day just to do preventative and chronic management. So that doesn't even include coming in for an ear infection or a sore throat or a sprained ankle. 18 hours a day. It's unsustainable, so you can think our primary care doctors go home every day essentially feeling like they have not done what they were supposed to do for their patients. So I think, and this is speculation, but I think if we do this right, is that mHealth technologies will dramatically change the practice of medicine, and that's at first blush concerning. But I think eventually, when done right, it'll free physicians of being directly involved in this very precision algorithmic medicine, for example, hypertension, that currently takes up the majority of their time. And instead, I think providers will be the diagnosticians and the educators that allow them to spend longer times with their patients. Patients will enjoy that. Doctors will enjoy that. But it's going to take, obviously, a huge change in incentivization, plus the tools for mobile health technology. So this is my final slide, and I think summarizes what I think the future of healthcare is going to entail. So that old model of going to this asynchronous care, now there's going to be much more connected care to your healthcare team. So the patient is now going to have the power to report their symptoms. They're going to be able to check all their vital signs as if you were in an emergency room. They're going to have devices with their EKG, their activity, their pulse oximetry, that whether they use their medication, what their blood pressure is, all of that's going to be sent securely through devices like the 2Net, and then physicians are going to be able to be the doctors they want to be, where they can be more that educator and diagnostician. So to answer the question, is wireless healthcare disruptive innovation? I'd say absolutely, but we have a lot of work that remains. Thank you very much.